Mitral stenosis. What are the causes of mitral stenosis? The most common cause of mitral stenosis in India is acute rheumatic fever. 40% of the individuals who develop acute rheumatic fever with rheumatic valvulitis are going to go on to develop a pure or a predominant mitral stenotic lesion. But with the incidence of rheumatic fever going down because of improved socio-economic conditions, because of more availability of antibiotics, the incidence of rheumatic fever is going down. Since the incidence of rheumatic fever itself is going down, the incidence of a rheumatic mitral stenosis is also decreasing in India. But it still remains the most common cause of mitral stenosis in India. Apart from acute rheumatic fever, the other causes of mitral stenosis include congenital mitral stenosis, because of some congenital abnormality in the papillary muscles or in the leaflet itself or the tensor apparatus. All right, all these are or the annulus. It can lead to a mitral stenosis. For example, parachute mitral valve. Parachute mitral valve is basically when there's a defect in the papillary muscles. Severe mitral annular calcification. The annulus is calcified and that calcification extends onto the leaflets, because of which the movement of the leaflet is going to get affected, leading to mitral stenosis. Left atrial myxoma. Depending upon the position of the left atrial myxoma, if it obstructs the flow from the left atrium into the left ventricle, it will lead to a mitral stenosis. Autoimmune conditions like systemic lupus erythematosus and rheumatoid arthritis can also lead to mitral stenosis. And large vegetation of any infective endocarditis on the mitral valve, which can again obstruct the flow from the left atrium into the left ventricle, is going to cause mitral stenosis. So what is the pathophysiology? What exactly happens to the valve? So in a rheumatic disease, the valve is inflamed. The valve undergoes inflammation. Inflammation is going to lead to thickening of the valve. The thickening is going to lead to deposition of fibrous tissue. The fibrous tissue can lead to deposition of calcium. It can get calcified, right? Lead to deposition of calcium. And then it will further lead to shortening, fusion and contraction of the commissures, the chordate Now what is a commissure? A commissure is basically a location where two objects meet. So in case of a cardiac valve is going to be where the two leaflets meet each other, right? So if that area gets calcified or fibrosed or due to any reason, it will lead to a narrowing of the area of the valve area. That is basically a stenotic valve, right? The valve cusps become rigid and there is a narrowing at the apex. Narrowing at the apex of the valve, because of which the valve takes a funnel shape, right? The funnel is narrow at the apex, right? A funnel, yeah. So it takes the shape of a funnel and it's called as a fish mouth valve. So rheumatic mitral valve is usually in the shape of a funnel. It's called as a fish mouth valve. Apart from rheumatic valvulitis, otherwise it can lead to calcification. The mitral valve can get calcified. The calcifications are going to immobilize the valve, and because they immobilize the leaflet and the valve, it narrows the orifice. And the initial process of the fibrosis thickening and this will be rheumatic in origin or maybe calcific in origin, but because of the because of the narrowing of the valve area, there is turbulent flow, altered blood flow across the valve. Turbulent flow is going to cause more damage. It's going to cause more damage to the valve, which will lead to thrombosis or embolization and further complications. So this is the pathophysiology of how the valve orifice narrows. What is the pathophysiology of mitral stenosis? So now this is the heart. And the mitral valve. Now, the mitral valve is narrowed, right? So the outlet between the left atrium to the left ventricle is narrowed. That is why the left ventricle is going to fill less amount of blood is going to flow from the left atrium into the left ventricle. Thus, left ventricular filling is going to go down. Left ventricular filling is going to decrease. That is, the left ventricular end diastolic volume is going to go down. The left ventricular end diastolic volume decreases, your stroke volume is going to decrease. Your stroke volume decreases, meaning your cardiac output is going to decrease. Okay. Now LA is not emptying into the left ventricle. Therefore, LA has an increased pressure in it. Now, LA is a very compliant chamber. So left atrium is going to increase in its size to accommodate the extra volume and the extra pressure that remains inside. That extra pressure is going to get transmitted back to the pulmonary veins. Through the pulmonary veins, that pressure gets transmitted back to the pulmonary capillaries. So the pulmonary capillary wedge pressure is going to rise. It further will get transmitted back to the pulmonary arteries, to the right ventricle. The right ventricle will undergo a hypertrophy because of that, and it can also lead to a functional TR. Okay, excessive blood flow across a normal tricuspid valve will lead to a functional TR. Right? So this is the pathophysiology. And because of the enlarged left atrium, the left atrium is going to become more susceptible. There is electrical and mechanical dysfunction. It's going to lead to atrial fibrillation. And atrial fibrillation will lead to thrombus formation. Thrombus formation will complicate as a systemic embolization. So that's the basic pathophysiology behind mitral stenosis. So the mitral stenosis is going to lead to a decreased LV filling, which will lead to a decreased stroke volume, which will decrease the systolic blood pressure. It is also going to lead to an increased LA pressure, which is going to lead to a pulmonary congestion, pulmonary hypertension, right ventricular hypertrophy, right ventricular failure. And the increased pressure is also going to lead to an increased LA pressure is going to lead to an increase in the LA size, LA enlargement. LA enlargement will lead to atrial fibrillation, and atrial fibrillation can complicate as embolization, will lead to a thrombus formation. Thrombus formation can embolize. So that's about the pathophysiology of mitral stenosis. What is the normal area of the mitral valve? The normal area of the mitral valve is around 4 to 6 centimeters square. When do you say it is a mild mitral stenosis? When your mitral valve area is between 2.5 to 4 centimeters square. Moderate is around 1.5 to 2.5 centimeters square, and severe is less than 1.5 centimeters square. Now, what are the clinical features of MS? If you correlate with the pathophysiology, you will be able to understand the clinical features of MS. Now, in a mild MS, the patient is able to maintain enough cardiac output at rest. Okay? So, the left atrial pressure is going to increase only mildly, and the patient will have no symptoms. But when the heart rate increases, in a case of a fever, exercise, anemia, thyrotoxicosis, pregnancy, what happens when your heart rate increases? When your heart rate increases, your diastolic time goes down. Diastole is the time when a left ventricle fills, when a left ventricular filling takes place, right? So if your diastole decreases, your left ventricle is not going to fill. The left ventricular filling has decreased. And the left ventricular filling has decreased, that means there is more volume in the left atrium. And the left atrium has to create more pressure to fill the LV. So LA pressure, it has to contract more, it has to generate more pressure to fill the LV. The LA pressure is going to rise. When the LA pressure rises, that LA pressure is transmitted backwards into the pulmonary veins and to the pulmonary capillaries, which will lead to pulmonary edema. And pulmonary edema leads to dyspnea. So when the heart rate rises, the patient will have dyspnea. So exertional dyspnea is the earliest symptom of mitral stenosis. Whenever the heart rate rises, the diastolic time goes down, LA pressure is going to increase, LA pressure is going to get transmitted backwards. It's going to cause pulmonary edema and exertional dyspnea. When there's a moderate MS, that is the size of the valve is between 1.5 to 2.5 centimeter. The LA pressure rises even at rest. The LA has to generate pressure to fill the left ventricle even at rest. So pulmonary venous pressure rises, that pressure gets transmitted backwards, LA pressure gets transmitted backwards to the pulmonary veins, to the pulmonary capillaries, to the pulmonary artery, right? With the rise in the pulmonary left atrial pressure, there is an electrical and mechanical dysfunction, which will lead to a arrhythmia. The most common arrhythmia is atrial fibrillation. So it predisposes the patient to atrial fibrillation. Thus the patient is going to present you with palpitations. AFib will lead to a palpitation and thrombus formation. Palpitations and thromboembolism. So LA pressure increases even at rest. There is electrical and mechanical dysfunction. The LA enlarges, which will lead to atrial fibrillation. So the patient will present you with palpitations and thrombus formation. And the thrombus formation can lead to a thromboembolism. The patient will have dyspnea with minimal activity. That means dyspnea even at rest, right? And which can progress to orthopnea and TMI. Because of the increase in the LA pressure and the pressure getting transmitted backwards, the patient will have a pulmonary hypertension. The pulmonary hypertension can further lead to a right ventricular hypertrophy. What are the symptoms of or signs of right ventricular hypertrophy? There's a loud and a palpable P2. You can have a left parasternal heave, elevated JVP, functional TR, and epigastric, suprasternal and second left intercostal space pulsations. In case of a severe MS, the mitral valve area is less than 1 centimeter square. The LA pressure is extremely high, which will again obviously get transmitted backwards with an increase in the pulmonary capillary wedge pressures, pulmonary arterial pressures in the range of more than 50 mm of Hg, which will lead to a right ventricular hypertrophy and a right ventricular failure. So signs of when the patient presents to you with the sign of right ventricular failure, with meaning ascites, ankle edema, hepatomegaly, that indicates that the patient is in severe MS, or the patient has severe MS. What are the other symptoms that the patient can present with? Other symptoms can be persistent cough, mainly due to increased pulmonary congestion. Because the LA pressure rises, it gets transmitted backwards, there is a pulmonary congestion, which can lead to a persistent cough. Recurrent pulmonary infections like bronchitis, bronchopneumonia, again because of increased pulmonary congestion. There can be a hoarseness of voice, Otner's syndrome. Why? Because the enlarged LA compresses the recurrent laryngeal nerve. There can be a recurrent pulmonary embolism. There can be systemic embolization. Sometimes the patient can present to you with a systemic embolization as a presenting feature of mitral stenosis because of the LA thrombus, right? And hemoptysis occurs because of the rupture of the bronchial and the pulmonary veins due to the increased pressure. What will you find on examination? On examination, the pulse will be normal and regular unless the patient has a severe MS where the cardiac output has also fallen down, in which the pulse will be of a low volume pulse. The pulse will be irregular if the patient has atrial fibrillation. The BP remains normal unless again it's a very severe MS where the cardiac output has fallen down, in which you're going to have a fall in the systolic blood pressure. JVP may be elevated in case of a moderate MS where there is a right heart failure or a right ventricular hypertrophy leading to a right heart failure, which can elevate the JVP. Edema, again you see in a severe MS, which is a sign of a right heart failure. On inspection, what will you find? You will find a malar flush, pinched blue faces. All this is because of a reduced cardiac output, reduced forward output. You may have an elevated JVP in case of a right heart failure. On palpation, you may have features of pulmonary hypertension or a right ventricular hypertrophy. If there is a right ventricular hypertrophy, you have left parasternal heave. You have a left parasternal heave. You can have a diastolic thrill. Diastolic thrill will be heard only when the murmur or MS is of more than grade 3. More than grade 3 murmur, you will have a diastolic thrill. And where will you feel this thrill? You will feel this thrill at the apex and best felt in the left lateral recumbent position. You may have a palpable P2, that's because of pulmonary hypertension, and a tapping apex beat. Tapping apex beat meaning the apex beat is going to come and hit your finger, but it won't uplift your finger. And the apex beat is not displaced. You will find it in the 5th intercostal space medial to the mid-clavicular line. 1.5 centimeter medial to the mid-clavicular line in the 5th intercostal space. On auscultation, S1 is going to be loud because mitral valve is stenosed. It is the leaflets have become rigid, so when they close, they're going to make a loud sound. S1 is going to be loud. S2 will be palpable and loud if there is a pulmonary hypertension, of course. And you're never going to hear a S3 and an S4. Why? Because, like we saw in the pathophysiology, the left ventricle, the cardiac output goes down because there's an obstruction to the blood flow from left atrium to the left ventricle. The left ventricle is one chamber which does not get affected in case of a mitral stenosis. So the outflow has reduced from the left atrium to the left ventricle. So the left atrium has enlarged. The pressure is getting transmitted backwards. The right ventricle can get affected because of the increase in the right ventricular pressure or the right ventricular hypertrophy. You can have a functional TR which can affect the right atrium as well. But your left ventricle is something that does not get affected at all. So your left ventricle has not failed. If your cardiac output is going down, it is because of the obstruction from the left atrium to the left ventricle, not because your left ventricle is failing. So S3 and S4 are sounds which you hear in a heart failure when the left ventricle fails. But in case of an MS, left ventricle is not affected at all. The left ventricle does not fail, and thus you will never hear an S3 or S4 in a case of a pure MS. What are the other sounds that you can hear in case of an MS? Other sounds that you can hear is, other added sounds are an opening snap, which occurs after A2, that's after the second heart sound. And the duration between the opening snap and A2 inversely correlates with the severity of the MS. The closer the opening snap to S2, more severe is the mitral stenosis. The cardiac output. The cardiac output remains normal even in moderate MS, even at rest. The cardiac output drops in a case of a severe MS, and especially in those people who have a severe pulmonary vascular resistance. So the cardiac output may be subnormal at rest and may fail to increase on exertion. Okay? Usually the cardiac output remains normal in case of a MS, unless it's a severe MS with a very high pulmonary vascular resistance, in which the cardiac output may remain less and may even fail to increase on exertion. Now, MS leads to back pressure changes and causes pulmonary hypertension. Harrison mentions 4 causes of pulmonary hypertension, which include the passive backward pressure because of the elevated LA. Second is pulmonary arteriolar constriction. Basically, the LA pressure rises, there is an increased pulmonary venous congestion that leads to a reactive pulmonary hypertension. The increased pulmonary venous congestion will lead to vasoconstriction in that area, which will lead to a pulmonary hypertension. This is called as second stenosis. Interstitial edema in the wall of the small pulmonary vessels leads to pulmonary hypertension, and the obliterative changes that will occur in the pulmonary vascular bed will also lead to pulmonary hypertension. And when we treat MS, we reverse the first cause. We reverse the passive backward elevated pressure of LA, thereby reducing the pulmonary hypertension. Now, in a case of mitral stenosis, what are the pulmonary changes that take place? There is a fibrous thickening of the alveoli and the pulmonary capillaries which occurs, because of which the vital capacity, the total lung capacity, the maximum breathing capacity, everything decreases. The pulmonary compliance falls. The pulmonary capillary pressure increases during exercise. Basically meaning all your vital capacities go down and your pulmonary vascular resistance has increased. And like I have already said, there is, because of the enlargement of the left atrium, there is stasis of the blood in the left atrium, because of which there is a thrombus formation, which can lead to a systemic embolization. The incidence of systemic embolization is 10 to 20%, especially in patients with atrial fibrillation, with the decreased cardiac output and age of more than 65 years. The incidence of atrial fibrillation increases with age. And it does not correlate with the severity. And systemic embolization sometimes can be the presenting feature in a patient with mild MS. What is the murmur of MS? The murmur of MS is classically described as a low-pitched, rough, rumbling, mid-diastolic murmur, which is best heard with the bell of the stethoscope at the apex, that is the fifth intercostal space, 1.5 centimeter medial to the mid-clavicular line, in the left lateral recumbent position. It is best heard in expiration. It has a pre-systolic accentuation. It can be associated with a chill, a loud S1, an opening snap. May be radiating or may not be radiating to the axilla. The duration of the murmur correlates with the severity of the murmur. And the A to OS gap, it is inversely, the severity of MS is inversely proportional to the A to OS gap. Narrower the A to OS gap, more severe is the MS. Now, how will you draw this murmur? So, this is a diastolic murmur, right? It is a mid-diastolic murmur. So, your S1, S2, S1. Since it's a diastolic murmur, this murmur is going to come between your S2 and S1, right? So, in your diastole, you're going to have this opening snap and you'll have the murmur, which decreases. And then there is a pre-systolic accentuation of the murmur. Why is there a pre-systolic accentuation of the murmur? So when that is in the late diastole, pre-systole meaning at the late diastole, and that's a ventricular diastole I'm talking about, right? So late ventricular diastole is the time when your atria contracts, right? So during the late ventricular diastole or pre-systole, your atria contracts. Once your atria contracts, there will be a flow of blood from the left atrium into the left ventricle across the stenosed valve, across a narrowed valve, because of which you hear the murmur, because the blood is flowing from across a narrow valve. That is why you hear the murmur. So when the left atrium contracts and pushes the blood from the left atrium into the left ventricle via a narrowed valve, you hear the murmur, right? That is why there is a pre-systolic accentuation just before systole, because the atria contracts, pushes the blood into the left ventricle across a narrow valve. You have this murmur that you hear. Okay, the pre-systolic accentuation, that is the cause for pre-systolic accentuation of the murmur. What are the other associated lesions with mitral stenosis? you can have a severe pulmonary hypertension. The severe pulmonary hypertension can lead to a right ventricular hypertrophy, which can lead to a functional TR. Right? Meaning, because of the pulmonary hypertension, the right ventricle has to pump against the increased pressure, which leads to a functional TR. The tricuspid valve is normal, but because of the increased flow, increased volume, you have the murmur. There is increased flow across the normal tricuspid valve, because of which you have a functional TR. So because the TR, tricuspid regurgitation, you hear a pansystolic murmur, which is audible along the left sternal border. And because it's a right-sided phenomenon, that is why it's going to increase with inspiration and decrease with expiration. And this sign is called as Caravello's sign. Another associated lesion is a TR murmur, a pulmonary regurgitant murmur. That murmur is named as a Graham-Steele murmur, which is a high-pitched, diastolic, decrescendo blowing murmur, which is audible again along the left sternal border. And again, since it's a right-sided lesion, it is going to increase with inspiration and decrease with expiration. What is the differential diagnosis for the mid-diastolic murmurs? So like we saw, mitral stenosis is a mid-diastolic murmur. What are the other murmurs that can be heard in the mid-diastole? MR. Now MR is usually a pansystolic murmur. But now the left ventricle has pushed blood into the left atrium, and from the left atrium this excessive blood is going to flow across a normal mitral valve. Right? That is why it's a flow murmur. So that's why MR can be associated with the mid-diastolic murmur, which is a flow murmur. Okay? Austen-Flint murmur of AR. The Austen-Flint murmur, basically the regurgitant jet hits the anterior mitral leaflet, because of which there is a murmur which is produced. Austen-Flint murmur, which is again a mid-diastolic murmur. In an atrial septal defect, what happens in an atrial septal defect? There is a right to left shunt. The blood is shunting from the right atrium into the left atrium. So left atrium will have a volume overload. So excessive blood is flowing across a normal mitral valve. Right? That is why you will have a flow murmur again, which is again a mid-diastolic murmur. Left atrial myxoma. Left atrial myxoma, depending upon the position, like I said, it obstructs the emptying of LA into the left atrium into the left ventricle, because of which it can cause narrowing of the valve area and will lead to a mid-diastolic murmur. And we have a Carey-Coombs murmur. Carey-Coombs murmur is a mid-diastolic murmur, which is a sign of active rheumatic valvulitis. It is localized to the apex. Okay? It varies in intensity from day to day, and once the acute attack of rheumatic fever or rheumatic valvulitis disappears, the murmur also disappears. But how will you differentiate it from MS? There will be no loud S1 and there will be no diastolic thrill. Okay? So these are the differential diagnoses of a mid-diastolic murmur. Mitral regurgitation, Austen-Flint murmur of AR, atrial septal defect, left atrial myxoma, and Carey-Coombs murmur. Now when a patient presents to you with MS, what investigations will you do? You will do an ECG. What are the findings you see on an ECG? You're going to see a biphasic or a broad P wave because of left atrial enlargement. You can also have features of severe pulmonary hypertension, like right ventricular hypertrophy. That means you'll have a positive, you'll have a R wave in the right-sided leads, V1, V2, you'll have R waves. You can have a RSR pattern, like a pattern of RBBB, right? And you'll have a right axis deviation on an ECG. So, P mitral and features of severe pulmonary hypertension or a right ventricular hypertrophy on an ECG, right? Then you will do a chest X-ray. On an X-ray, what will you see? You will see a double atrial shadow. Your left atrium has enlarged, because of which you are going to see a double atrial shadow. You will have the left atrium is going to uplift the trachea. That's why we'll have the widening of the carinal angle. There will be prominence of the pulmonary arteries and the veins because of the pulmonary hypertension. The LA pressure is increasing, causing the backward pressure, pulmonary hypertension, curly V lines, right? All these are which is a feature of pulmonary edema. You will be seeing that on an X-ray, and you'll have the straightening of the left heart border. Right? And an echocardiography. What do you see on an echocardiography? You will be able to see whether there are any other associated lesions. You will be able to see the size of the valve, according to which you can grade it with as mild, moderate, severe. You'll be able to see the hemodynamic severity and all these things, and you'll be able to decide on to the further treatment of the patient. What is the treatment of the patient? Well, like we saw, if the heart rate increases and your diastolic time goes down, the left ventricle is not able to fill, because of which the LA pressure rises, or LA pressure has to rise more to fill the left ventricle, right? So if you decrease the heart rate or keep the heart rate under control, your symptoms are going to decrease. Thus, you give agents that are going to decrease the heart rate, like beta blockers, non-dihydropyridine calcium channel blockers like diltiazem, verapamil, and digoxin, which decrease the heart rate and prevent the LA pressure from rising too much. You will also give a diuretic. Why? Because there is a pulmonary edema, pulmonary congestion. So you try to wash out the pulmonary congestion by putting a patient on a low dose of diuretic. Salt restriction helps. Anticoagulation. Anticoagulation you give only in case the patient develops a atrial fibrillation. If the patient does not develop atrial fibrillation, there is no use of giving an anticoagulation. There is no indication to give an anticoagulation. And in a patient who has developed a new onset AF with a very mild MS, you can try to revert, instead of an anticoagulation, try to revert the patient back to a sinus rhythm. Okay? That is the medical management. As for the surgical management, a symptomatic patient, that is NYHA grade 2 to grade 4 with a severe MS, should undergo a balloon valvotomy, or now it's known as a percutaneous mitral balloon commissurotomy. There are a few contraindications to this, like if there is a commissural calcification, LA thrombus, if the leaflets are calcified, right? If the leaflets are not pliable, they are not free if they are calcified, and if there is a MR of more than grade 2. That's a contraindication to do a percutaneous mitral balloon commissurotomy. Why so? Because if you see, you basically insert the guide wire and the balloon through the femoral vein come to the IVC, go into the right atrium, you do a transseptal puncture and you enter the left atrium. From the left atrium you go into the left ventricle and then you inflate the balloon. Now if there is some calcification on the commissure, near the commissure, when you try to inflate the balloon, you may rupture the calcification, right? And that can embolize anywhere. So commissural calcification will be a contraindication to do a percutaneous mitral balloon commissurotomy. If there is a LA thrombus here, while puncturing the septum or while going from the left atrium into the left ventricle, you may dislodge the thrombus and again cause some embolization. So again, that is a contraindication to do a TMBC. If the valves are calcified, again, you will not be able to push this guide wire through the valve and be able to inflate the valve. The valves need to be freely mobile to be able to do this procedure. So that becomes a contraindication. And if if you have an associated MR of more than grade 2, that is a contraindication for a percutaneous mitral balloon commissurotomy. So, a rheumatic mitral valve, which is severe. A severe mitral valve is an area of less than 1.5 centimeter square. So, the patient is symptomatic, NYHA grade 2 to grade 4. Check if there is no contraindications, like the valve is pliable, there is no LA thrombus, or there is no clot, right? There is no calcification, and your MR is of less than grade 2, you will do a commissurotomy. Okay? If that's not possible, if the valve is not pliable, if there is a LA clot, or there is some contraindication, if MR is of more than grade 2 and the symptoms are still severe, the patient may be a surgical candidate. You will do a mitral valve repair or a mitral valve replacement surgery. For a patient who is asymptomatic with no contraindications, if the patient has a new onset AF, or if the pulmonary arterial pressure is more than 50 mm of Hg, the patient should undergo a commissurotomy. Okay? And in case of a progressive MS, meaning it is not a severe MS, that means the valve size is more than 1.5 centimeter square, but the patient has symptoms on exertion, the stress test is positive, patient becomes hemodynamically unstable when on exertion, right? So in these conditions, check if there is no contraindication and the patient should undergo a commissurotomy. Right? And when do you say that this commissurotomy is successful? You will say that the commissurotomy is successful when there is a doubling of the mitral valve area. So if the mitral valve area was 1.5 centimeter square or less than whatever, it should become 3 centimeter square. If there is a doubling of the mitral valve area after the commissurotomy and there is no MR, there is no residual MR, that indicates that your commissurotomy has been successful. That's the treatment for mitral stenosis.